I'd first like to acknowledge that this work was conducted in Alberta, specifically Calgary, which is located in the heart of southern Alberta. And I want to pay tribute to the traditional and existing territories of the people of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, Kainai, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, which includes the Chiniki, Bearspaw, and Good Stoney First Nations. City of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. So just a quick slide to orient to what I'm hoping to accomplish in the next about 35-40 minutes. Is I hope that you will understand the barriers and facilitators to implementing AI-based tools in healthcare, understand the differences and similarities between implementing AI-based tools and other interventions, and be able to maybe design some strategies for implementing AI-based tools based on identified barriers and facilitators. So first disclosure, so no financial disclosures. Any money I receive is from grants from CIHR, Canadian Cancer Society. Not important enough for people to pay me to do things. My disclosure here is that I am not an AI expert, not even close to an AI expert. I am also not a cardiology researcher. Most of the work that I'm going to show you today is kind of specifically related to a project for revascularization in patients with cardiac conditions. So I hope I see 50 participants. I hope not everyone's going to drop off with that disclosure that I am not an AI expert, and this isn't about AI. It's more about the implementation of AI. I did see Dr. Jin Lee online. I can always direct AI questions to him since he led a lot of this work. So what is AI? Artificial intelligence is the ability of a computer or computer-controlled robot to perform tasks that are commonly associated with the intellectual processes, characteristics of humans, such as ability to reason, discover meaning, generalize, and learn from past experiences. So this is a slide that Dr. Lee has used before. So really where AI is currently is this picture on the left here, where we'd be able to kind of train computers to identify a car from a bicycle and things like that. Whereas I think a lot of people think of Terminator and robots, and actually our data that I'm going to show you later on from patients asking their perspectives on AI confirms that this is in fact what a lot of people think about when they think of AI. So what can AI do? So it can learn optimal actions in trial and error data, which is considered reinforcement learning. So there's some examples of those. So the player that I play against and often lose against when I play Scrabble online, that's an example of that. It can discover patterns. That's considered unsupervised learning, and this is really the groundwork for the next part, which is making predictions, which is supervised learning, and considered one of the more successful uses of AI. And what this translates to in healthcare is clinical decision support tools, or I'm going to use CDST a lot just for brevity on the slides. So what are clinical decision support tools? Nowadays, they're computer-based. I'm sure some people probably remember checklists and algorithms and things like that, but now they're mostly computer-based. They can be passive or active delivery of information or suggestions. Sometimes they're evidence-based. I'm going to talk about AI-based clinical decision support tools. So while they are evidence-based because they're based on data and a computer's ability to learn from existing data, sometimes clinical decision support tools are actually interventions, not innovations, to implement evidence-based clinical practice guidelines and things like that. And usually clinical decision support tools include some degree of personalization. Some may think of it as precision. So there is an explosion of developing clinical decision support tools in healthcare. They're used in, I think there's probably examples in almost every field. They're particularly prevalent in diagnostic imaging, and in some areas more than others. So it's a really hot topic. There's a lot going on in this area. Some of them are AI-based, some of them are not AI-based, but there's a huge explosion of the development of clinical decision support tools in healthcare, largely based on the abundance of data now available. So clinical decision support tools actually have a decent amount of evidence in terms of effectiveness. There was one systematic review, which is not cited here, that found about 75% of studies looking at the effectiveness of clinical decision support tools on a variety of outcomes were positive studies. So they were effective at improving outcomes, regardless of what those outcomes are. However, that still leaves about a quarter of clinical decision support tools that were ineffective. So this study by Kawamoto in 2005, so getting to be a bit old now, kind of wanted to do a systematic review to understand what makes a successful clinical decision support tool as an innovation. So distinguishing it as an intervention, but actually as the innovation that you want to implement. So when the clinical decision support tools were integrated into an electronic medical record or something that was already being used for the care, and that also gets to the point as being at the point of decision making when you're actually seeing the patient, they were more effective than ones where you had to, go grab an app or a different tool. The actual recommendation that it makes was really, really important to its success as well, right? If it was easy to interpret and it was computer generated and it kind of was like there at the point of care, then that improved the effectiveness of the clinical decision support tools. If there was provider and patient engagement, so whoever the end user, like I don't need to tell anybody a knowledge translation talk that the end user is important, but this was also reinforced in their review. And there had to be kind of that stakeholder involvement or interested party involvement in the development and implementation. So acknowledging that there is a good amount of evidence, an increasingly amount of evidence saying that clinical decision support tools can improve outcomes, that we know a little bit more about what makes a good clinical decision support tool versus what doesn't. How can we actually use this to inform decisions and help improve patient outcomes? So Dr. June Lee led this work looking at leveraging big real world data. So we use the approach registry here. So it's a clinical and administrative data repository that has collects patient data for all patients who had some kind of cardiovascular issue. And so all kinds of cardiovascular patients. And he wanted to leverage this data to help develop a clinical decision support tool. And innovatively, because a lot of the studies, and I'll talk about this a bit later too, a lot of studies looking at AI-based clinical decision support tools really just focus on the validation and maybe a trial looking at effectiveness of that tool, but never really go into the actual implementation within healthcare, which is really the goal if it's going to be used, and the benefits then are translated to patients. So innovatively, June Lee, when he was thinking about developing this AI-based clinical decision support tool, decided to include some of us in knowledge translation and implementation sciences so that during the actual design and development phase, he already knew what was needed to then be able to implement it into clinical practice. So that's where I came in. I was lucky enough to be approached by Dr. Lee and asked to do some of the preliminary knowledge translation implementation science work on this. So using the knowledge to action cycle, we started trying to engage with interested parties and knowledge users for the tool to understand what is needed to develop a tool that's going to actually be able to be implemented within the healthcare system. So the first step was to do a World Cafe. So for those who are not as familiar with a World Cafe methodology, it's a way of presenting evidence to a group of interested parties and your knowledge users, but then also generating evidence or data from your interested parties. I kind of say that it's almost like simultaneous focus groups at the same time. So we presented data on the effectiveness of clinical decision support tools, gave some evidence around what makes essentially all the evidence that I've just presented already around what makes a good clinical decision support tool. And then asked our participants our participants were a diverse group. So we had some patient partners, we had a variety of cardiology, healthcare providers, so cardiologists, interventional cardiologists, cardiac surgeons. I think we had some residents in there too, as well as decision makers within cardiology in Alberta, so operational leads. And we also had an industry partner, since the idea is to probably commercialize the clinical decision support tool that is being developed. So within this group, we asked, what is most difficult about making decisions around how to revascularize? So surgery, CABG, or stenting. How could artificial intelligence be used to integrated into the clinical workflow? And what are the critical components to artificial intelligence tool that need to be considered when developing the tool? So around the first question, what is needed? Is there a need? Is this even an area of clinical practice that is challenging and that needs an intervention? The answer was yes. It is a very complex time trying to make a decision around how to revascularize these patients. So one thing that the knowledge users identified was data availability. So often data isn't available for the patients kind of quickly in a timely fashion before they have to make a decision. And obviously a lot of these patients, urgent decisions need to be made. So there isn't a ton of time to kind of collate all of their information. So being able to having the data available is really important when making these decisions. Workload and resources, I don't think this is particularly surprising when talking about any healthcare system, any area of healthcare right now. Having the resources to make these decisions and care for these patients. There was also quite a bit of discussion around physician burnout. This was done about a year ago, so obviously a little closer to the end of kind of the acute COVID periods. Patient characteristics were particularly challenging. So having that data available around the holistic view of the patient and all of their comorbidities and preferences, but also trying to take all of those things into consideration when making these decisions. And standardizing. There were some guidelines available, but there is some incongruencies between some guidelines, so that made it more difficult to make these decisions. So that gave us a clear understanding of what are some of the challenges that the providers are facing when trying to make clinical decisions. So then we asked, do you think there's a role for AI or clinical decision support tools here? And there was a resounding yes. But there was a but. But the AI had to have certain characteristics. So it needed to be end user built. So they wanted, I mean, all participant groups from healthcare providers to patients wanted to be involved in how it was built and what it would look like. There was a concern about the score and our output. I think there are some clinical decision support tools within cardiac care. And one of the comments from healthcare providers who were trying to think about using them was that it just, the score and the output didn't make sense. They weren't really sure how to interpret it. It needed to be evidence informed, and that kind of gets to the validity of the tool. There were obviously some issues around data privacy, IT, how it would integrate within the EMR. And it really needed to focus on patient characteristics. So a lot of those factors that go into prognosticating patients' outcomes needed to be included. And both patients, all of the groups who were represented in the World Cafe agreed that having a component that was patient-facing would make it far more effective. So just to kind of summarize all of the data from the World Cafe, one of the most critical components was that it be evidence-based. So needed to also be congruent with their existing views and the clinical practice guidelines, but obviously it had to be valid. It had to consider workload and resources. So would it actually be integrated within the healthcare, the EMR? Would they have to, get a different app? How would that look like in terms of workflow? The data requirements were that it be patient-centered, data-driven, evidence-informed, and have data actually integrated it into the tool fairly real time. In terms of characteristics of the tool, again, end user built, user-friendly, accessible, and easily used within the EMR, and that also flowed into the incorporation with workflow. So we had a good understanding, a preliminary understanding of kind of the need for maybe an AI tool, how the vision, but we wanted to get a broader perspective. So the World Cafe was with our advisory group. And again, it was a very diverse group of people. However, it was people who are probably more likely to be early adopters, right? They were engaged and wanted to advise us on this study. So we wanted to get a larger perspective from providers. So we actually intended to do a mixed method study, but we ended up doing surveys because we were finding it incredibly challenging to recruit healthcare providers for interviews. So that potentially a limitation, but also a learning point for us. So through interviews, we had 50, I believe it's 55 responses from across the province. So this was a provincial study. And from the representativeness was actually quite good in terms of responses, in terms of what type of healthcare provider, were they a cardiologist, were they a cardiac surgeon? We had some nurse practitioners. And in some of the healthcare providers practiced in rural settings, most of them were urban settings, but there was quite a bit of representation in the surveys. So some of the first questions we asked were just about their use of clinical decision support tools. So 83% said that they were already using some clinical decision support tools in their clinical practice, but only about 33 said that they were using AI-based clinical decision support tools. And that's maybe is not necessarily related to revascularization, like the tool that's being developed, but just in general. So there was quite a bit of use of clinical decision support tools, but less in terms of AI-based clinical decision support tools. So when we use the theoretical domains framework to ask some questions around barriers and facilitators, this is what we came up with. So just to highlight that everything, all the bars that are shorter were the barriers, anything that was longer would have been the facilitators, just in terms of how we ask these questions. Time constraint was a big concern. So if it's going to take extra time for them to find the tool or use the tool, that was going to be one of the major concerns. Access to the tool was a concern. How would they actually access the tool? And whether or not there was support and resources for using the tool. And this can come down to as well as IT, like is there the IT infrastructure? What happens if the tool's not working? How would they be able to receive resources for that? And you can see on the contrary, some of the facilitators were like, they liked that it would standardize care. They thought it was worth the effort of using these tools because of the effect it would have on patient outcomes. We're also interested in the patient perspective, because if healthcare providers are using these and patients don't see the value or are concerned about them, that's obviously a big issue. So we did do a mixed method study with patients. So it was a sequential explanatory. So we started with the survey to kind of get a snapshot of what patients' thoughts were around using AI. We didn't use the terminology clinical decision support tools as much as kind of like AI tools, just to kind of have that orientation. And then we did interviews with, so the number of patients that responded to the surveys, I think, was around 60, and we did 10 interviews with patients to try and understand some of the responses that we got on the surveys. So some of the major concerns from patients around their healthcare providers using AI to make decisions around their care was you'll see some consistency or some variations in all of the ones. So using the tool would reduce interaction with their healthcare providers. They felt like they may not be as big of a participant in the decisions made about their care if AI was kind of making suggestions about how their care. And there was also some current concerns about who's responsible if an error is made in the choice for my revascularization, who's responsible for that error? And that was also tied to some of the data that we got from the qualitative interviews, where patients really value healthcare providers, especially physicians, clinical expertise, the education they've had, the experience they've had, and they really value that. And they were afraid that AI would take some of the physicians' kind of, clinical decision based on their own clinical experience away from the decisions being made about their care. I will say too, I didn't have it. I didn't put in a slide for the qualitative data, but I will also say that one of the first questions we asked patients when we did interviews is, are your healthcare providers using AI-based tools to help guide your care? The majority of people felt that their healthcare providers were. When we asked them about their perspectives of like, what is an AI-based tool? How is AI used in healthcare? Most people did go to the kind of that, the robots. They thought it was robotic surgery. They thought it was like diagnostic tests. So their perceptions of what AI is in healthcare it was certainly different than what we're proposing to develop, a clinical decision support tool. And it is still very focused on robots, which I found very interesting. And that is even after considering that about 40% of participants in the interviews were actually had some professional role within healthcare or computer sciences. So these were, fairly educated people in terms of healthcare and computer science, data science, and still the perception really around AI and healthcare is really robots and surgery and interpreting diagnostic tests. So I thought that was also very interesting. But again, from the qualitative data, there was actually far less concern around data privacy, data breaches, things like that, and more around this interaction with the healthcare provider and responsibility for their care. So I'm putting up the CFR here just as a reminder. So a lot of the barriers and facilitators that we identified were really at the individual level, but refer to things in the inner setting, right? So the infrastructure within, say, the hospital, the EMRs, and as well as the outer setting, and also refer to the thing, the innovation, which would be the AI-based clinical decision support tool, right? There's a lot that goes into building the tool so that it is implementable. And that is actually ongoing right now. During the development, there will be engagement with human factors experts to make sure that it's being developed in a way that adheres to some of the concerns that were raised. But getting back to kind of the individual level barriers and facilitators, these are, collating all of that evidence that we generated. These are the main barriers that were identified. So in terms of opportunity, using the COM-B, social influence was a big factor. So if there were other providers using these tools, especially since a lot of the decisions around revascularization are made in case rounds, I think that they thought like if one person was using it would then kind of spread to the other practitioners. The environmental context was absolutely huge. Like time and time again, having it integrated within the EMR, not decreasing or not increasing the resources required to provide care was probably one of the biggest factors across all of our data. Motivation had several barriers, right? So role and identity, they were afraid that if it was AI, these tools were AI-based and not based on clinical practice guidelines, that the recommendations would be counter to some of their currently held beliefs about how care should be provided and who should have, cabbage versus stunting and things like that. There was some emotions, right? Kind of also related to that, like what if it says that a patient should go to surgery, but I just don't think that that is the right option. And it gets to consequences because they're afraid that if the AI-based clinical decision support tool makes a recommendation for care, and then there are negative consequences, like how do they reconcile that? Knowledge, memory, and attention were also less endorsed barriers. So I think, you know, the common idea of like education, training was necessary, but probably isn't going to be sufficient for implementing these tools, but again, is necessary. And then memory and attention came into play in terms of just making sure that the tool, they don't have to think about using the tool, it's kind of available to them without them having to remember to go and find the tool somewhere. So this was within, you know, context is huge. When you're thinking about knowledge translation implementation science, context is huge. Our context is this was done in Alberta. This is specifically looking at revascularization, so the care of patients with cardiac conditions. But how does that generalize or translate to other settings within healthcare? So we also did a scoping review, so none of the work that I'm showing here has been published, but is completed. The scoping review is still being completed. So I'm just presenting some preliminary work, and we have some more work to do. So we did a scoping review looking at what evidence exists for barriers to facilitators and implementation of AI-based clinical decision support tools. We wanted to see if there were any barriers to facilitators identified by others in other contexts that maybe we should think about when we're trying to develop this tool and then implement it. Sometimes the perceived barriers and facilitators are not always super comprehensive. Sometimes people don't realize that something's going to be a barrier when you're asking them. So we wanted to make sure we had a really comprehensive understanding of potential barriers and facilitators that might come up when we're trying to implement. So we ended up including 65 papers, and I have this arrow here just to highlight. We excluded a tremendous number of papers because they didn't identify any barriers for facilitators or talk about implementation. The vast majority of research done in AI-based tools or AI-based clinical decision support tools is really around validation of the tools with little consideration for actually implementing the tools. So this scoping review, the 65 papers represented papers that were published. There was one published in 1985, clearly ahead of its time, and then all the way to 2023 with a median publication date of 2020. The majority of the studies that we identified were done in the United States, quite a bit here in Canada. The study design, we did not limit based on study design. The majority were qualitative studies. There were a handful of reviews, mixed method studies, lots of opinions and position papers, and they were quite diverse in terms of the clinical areas they covered. So you can see here there were 5 actually in cardiology, which is particularly helpful in guiding this work. There were some that were just generally speaking, what are barriers and facilitators to using AI-based tools, AI clinical decision support tools. Hospital was kind of another big area that was looked at in this review. I apologize, the words are a little bit small here, so I'll kind of guide you through. We used the theoretical domains framework to try and categorize the barriers and facilitators that were noted in all of the papers. And so very much aligned with our study, a huge proportion of the barriers were related to the environmental context. Again, this was brought up time and time again in our study around the resources, having it at point of care, not increasing workload. A lot of the other barriers were related to beliefs and capabilities, and also knowledge was a big barrier to using. And this was more around awareness of the actual tools, but also around kind of credibility and feeling like the tool is credible and valid. Social and professional role was probably the next most common barrier identified. Facilitators were actually fairly similar. So, you know, kind of the flip side of the same coin. So if people were knowledgeable about the tool and how the tool was created and the validity and credibility of the tool, that would facilitate their use. environment and context. If it was well integrated into existing workflow, then that would increase their likelihood of using the tool, beliefs about consequences. So very similar barriers and facilitators identified, and actually quite a bit of overlap with what we found, which is good because we don't think we missed any potential barriers and facilitators in our study, but also suggesting maybe they are generalizable beyond just kind of the Alberta and cardiac care context. I did want to note it that only 14% of the studies that reported barriers and facilitators actually used any theory framework or model. So CFR was used a few times. The technology acceptance model, which I was not aware of until I did this review, was the most predominant theory model that was used, as well as the constructive attitude. So very little theory-based barriers and facilitators assessment in the evidence that we found. We also abstracted data on any studies that actually did implementation or claimed to do implementation. When we think about actually evaluating the implementation using the RE-AIM framework, about 75% of the studies reported some variable related to reach. Only 33% reported variables related to effectiveness of the tool or adoption of the tool. Only a few studies reported anything related to fidelity or implementation, and none of the studies reported on maintenance. I will give the studies credit for maintenance because these were all published fairly recently. So in terms of, tracking the maintenance, they probably do need a little bit more time for maintenance, since this is an emerging field. So what now? So we have a good understanding of kind of the care gap that needs to be filled for the clinical decision support tool. We've done, I think, a fairly thorough assessment of potential barriers and facilitators. And the next steps are to build the tool. So we did all of this kind of before even actually building the tool. Through a lot of our surveys and questionnaires, we also provided links to existing clinical decision support tools so that participants would have an idea of kind of like what we meant by a clinical decision support tool. But the algorithms are just being finalized, and the tool is actually starting to be built as a tool that can actually be used by the end users. And then after the tool has been completed and is ready for testing, that's when the hard bit comes, is the actual implementation. So we've already started preparing kind of an implementation plan based on the barriers and facilitators that were identified, and have linked kind of the theoretical domains that were identified to the behavior change wheel interventions. And so some of our plans for the implementation bundle include having a champion. We do have some champions of this work already in some of the sites here in Alberta. So using them as ways of having that social influence. We have some training planned. Audit and feedback will also be included in terms of their use, and some training as well. And obviously evaluation of not only the effectiveness of the tool, but also the implementation is super important, given how little evidence there is around implementing AI-based tools or clinical decision support tools. I think this is critical in work that needs to be done so that it can inform other studies trying to implement AI-based clinical decision support tools, since this is really a budding area of research right now. So to summarize, barriers and facilitators for AI-based clinical decision support tools are broadly similar when we compare our findings to those of others, but as always with knowledge translation implementation, context does matter, but maybe a less rigorous barrier facilitator assessment needs to be done based on some of the evidence we've generated and the evidence generated by others in our scoping review. there is a lot to be learned around implementing these AI-based clinical decision support tools in healthcare, and evaluation using implementation science is really crucial to increasing our understanding and knowledge about implementing these tools. I just want to acknowledge the important work. So this work is led by Dr. June Lee, and these are our research assistants who have put in a lot of the grunt work, and acknowledging the funders of this work, CIHR and Alberta Innovates. Thank you.
Thank you, Khara. I would just like to give a round of applause on Zoom World to a great presentation and highlighting all the work you've done so far in terms of the knowledge generation in this area and the work moving forward into, as you mentioned, the big work is coming up with the implementation of this in terms of implementing it in Alberta. I would like to start with any questions from the audience out in Zoom land. As I mentioned, you can put a question in the chat box to Megan will read it out, or put up your virtual hand and come off mute, and please feel free to do it either way. Everybody's pretty quiet there, Megan.
Yeah, for the moment.
Oh, I see one.
Oh, I see Vincenza. Vincenza has her hand up.
Oops, there I am. Okay, hi there.
Hi.
It's always nice to speak to a person. I have a question in the beginning, and I apologize if I missed something. You chose to use the words AI rather than clinical decision support tool in your, in speaking to others. And I'm wondering, like, given all the stuff that goes around, and I know this research didn't start yesterday, so I understand that, but there is a lot of bias already, and you actually found that in terms of what people thought of AI. I'm wondering what was, like, maybe plain languaging clinical decision support tool, whether it would just be called a decision support, like something to help with our decision, something to help filter all the information we have. Would that have helped? I have no idea. You may have come up with the same outcome, but it's just that AI is so laden with so many biases and so many, Star Wars, robots.
So I mean, acknowledging words matter, right? Like the way you frame things for sure matters. We definitely, in the same way that I used AI to hopefully create buzz around my talk, we use that for recruitment for sure. When we were trying to recruit, we used AI a lot. So we did try and carry that into the way we worded things in the survey, because there is bias, but I think we were trying to actually get at some of that bias. Like, what did people think about that? We also did, and when we published, we will obviously publish the actual survey so you can see the wording, but we did say AI tools to guide decisions about how your care is provided. So kind of like, without saying clinical decision support tools, because I think that's like a term a lot of us researchers and healthcare providers are very used to, but maybe not patients. We did use those terms when we were talking with healthcare providers and decision makers. But we tried to frame it around AI tools to help inform how your care is provided. And would it have changed if we took out the AI? Yeah, maybe it would have. And I think we were, and this is maybe part of our bias, like trying to see, like, are patients okay with using their data to inform their care, and like data from other patients to create these patterns, right? Which would make recommendations on prognostication and care and treatment. I don't know if I have the right answer, but that was kind of our thought process.
I don't know that there is a right answer. Like, I mean, we just don't think of things in that way. Like, I mean, as a patient, I guess I'm thinking, I want to know what would help you make a decision, what would help me make a decision,
right,
rather than, it's AI or whatever. But no, I don't know. Like, when you figure that out, please publish.
I just wanted to follow up on that question, Khara, around this idea around, do you think there is a difference in how bears and facilitators would relate to the AI-based clinical support tools versus non-AI? You know, like how
Yeah,
do
so
you
whether it's
see
coming from like a
that?
clinical practice guideline and you're just
Yeah.
making it into a clinical decision support tool, which happens, right? Like that's kind of probably the more traditional approach to clinical decision support tools. I think that there is a little bit, right? I think it's this trust in our algorithms really able to make accurate decisions about how to treat patients. So, and again, that's kind of why we were kind of probing and using that term AI, was because we want to know if there's going to be an appetite for using a tool that's based on a huge amount of data and finding patterns in that data. So I think that does come up. That being said, I did a lot of work around kind of, bears and facilitators implementing guidelines in my PhD. And there is still that trust and credibility that comes up as a barrier when you're trying to implement clinical practice guidelines too, right? Like, do I really trust that people did a good job of synthesizing the evidence and doing a meta-analysis? Do I trust their clinical opinion? Because maybe it's not the same in mine. So I think there are some similarities. I think it's just a slight nuance on kind of that credibility. And actually, with AI, you can actually do validation, right? So you can actually tell people how accurate this prediction is.
Yeah, good point. Good point. Any questions, Megan, from the audience?
Not seeing any more questions at the moment.
Okay, then I'll carry on because I'm so interested in this and some of the work we're doing in terms of building these tools into a system like Epic and Connect
Right.
Care in Alberta. So the flip side of that is you mentioned the work you've done with patients, right? And important outcomes to them in this decision making. Can you comment on some of the outcomes that may be important to patients? Because we hear this a lot in our work in nephrology around the idea that everything that our decisions are made on might be, mortality, the risk of mortality, other things, but we've heard from patients that those are not necessarily important to them. So can you comment, and maybe this population or the work with AI and those outcomes that you might have heard some stuff through your qualitative work?
Yeah, I mean, so I usually work with patients with cancer. That's kind of my normal work. And yes, so a lot of times, especially patients with head and neck cancer, survival rates aren't terrible, but then they have long-term chronic outcomes that are often ignored because you're like, well, you survived. So yeah, I appreciate kind of that, like, those aren't always the important outcomes to patients. In this work specifically, there was some discussion around, and this was mostly in the World Cafe, where we had a diverse group together in one spot, around helping educate patients about why they, a lot of patients aren't going to want to have surgery. Like, if you're given the option between stenting and surgery, like, surgery is a pretty big surgery, and that's not really what you would choose to have if there were other less invasive options. But from the clinician's perspective, it goes beyond, like, well, you're younger, so if you have stenting, you're probably going to have surgery eventually, because, so I think there was that kind of patient education, and not so much in, mortality and quality of life were definitely brought up by patients, but I think actually some of the other outcomes were brought up by the healthcare providers, in terms of longer term decision making.
Thanks.
So we do have a question from Christy. And Christy asks, does your team have any suggestions or your own established barriers and facilitators on creating scoring systems that are useful and easily interpreted by the end user? And she added, I believe that was a concern of the knowledge user you presented, and rightfully difficult in CDSD creation. And I'm not sure what CDSD is, but
yeah, clinical
you
decisions.
probably know.
Yeah, yeah, I mean, great question. My short answer is no, I don't know. They did reference, some of their other clinical decision support tools that have been created, and the fact that they don't make easy recommendations. And I'm sure this probably has to do with liability, right? but they find that they're hard to use because then they don't really understand what the interpretation is. I know June Lee that's one of the considerations as they build the tool, and they're working with human factors experts to kind of navigate that. And I'm curious to see what it looks like. I'm super curious to see what it looks like.
Okay, thank you. Sorry, I didn't pick up on that acronym at the first pass.
That's okay.
there.
I didn't use the acronym. I tried to say it out.
Okay, then we have a question from Andrea. She said, great talk, Khara. Thanks for this. Perhaps a bit of a simple question, and maybe I missed this, but how are the AI clinical decision support tools different from the care pathway algorithms used a lot in Alberta Health Services?
Yeah, great. Thanks, Andrea, for the question. So my understanding of the care pathway algorithms in Alberta Health Services, that's more around like who goes where when. The AI-based clinical decision support tools are essentially being developed to help with clinical decision around treatment options. So, you know, this person has these characteristics, the likelihood of them having successful revascularization and good outcomes after CABG are this. So it incorporates, and the other thing is how it's making these suggestions. It's incorporating data on tens of thousands of patients, maybe hundreds of thousands of patients. June can correct me in the chat box. Based on, you know, all of the data from these other patients who have had revascularization, looking at their outcomes. So it's also the amount of data that's being input into these tools to make recommendations for treatment options.
Thank you. And next question is from Justine. She said, what I find interesting in your works with patients was their fear that the AI system could have an effect on clinician-patient interactions and on their own participation in the decision. Did this also come up in the interviews? And if so, could you elaborate a bit?
So it did. So this came up in the World Cafe from both patients and healthcare providers. And it did come up in interviews quite a bit in terms of, you know, having some ownership over the decisions made about their care. I think they felt that, you know, potential issue that would arise from using these AI-based clinical decision support tools is that a healthcare provider would, you know, have a recommendation and they wouldn't incorporate their own clinical perspective into that recommendation, and that there wouldn't be this discussion around patient preferences as well. So that did come up quite a bit, and I do think it was also raised by the healthcare providers as well, that they worry about how they communicate the recommendation from the tool with their recommendation, have that kind of discussion with patients. I think one kind of way of overcoming that barrier is to have, and this was, I'm not the one who's being novel and suggesting this was brought up in the World Cafe and in some of the interviews, is having a patient-facing component to the tool so that it can be a way of having a discussion about patient preferences, outcomes, processes of care, things like that with the patient and the healthcare provider. And I mean, we do know, like, if there's a patient, you know, to interventions, if there's some kind of patient-facing implementation strategy along with other knowledge user strategies, it really does increase the likelihood of it being implemented well. What patient-facing, what patient-facing means in terms of maybe the tool has an interface that can, you know, give the patient in terms that are appropriate, kind of like based on your characteristics and people who have had these procedures before. Their surgery is X% likely to result in revascularization. This is your risk of outcomes, things like that, to have a discussion with healthcare providers. Does that help? Sorry.
Yeah, sorry, I'm eating at the same time. That's why my camera was off, but Thank you very much.
Or maybe even have something around like, here are some questions you should, or some things you should discuss with your healthcare provider when making your final decision. And
Yeah, like
Okay.
some prompts, right?
yeah.
Or some prompts, like a read through questions or,
Have you guys done
and-
these though? Like, have you had patient facing? Because I know like Matt does so many.
yeah, not in the work I do in terms of chronic disease management, more so having prompt type of questions when you go to see your healthcare provider, be a pharmacist, primary care doc. But again, that's what we heard a lot of for patient-facing tools would be questions to ask your physician, because a lot of patients and caregivers say, if only I knew what to ask when I go to these appointments, right? There's so much, and especially in this population, there's so much going through their mind. So you feel like you don't have any control of what you should ask, and it's driven by the clinician instead of the patient or family. So
Yeah.
no, but there's lots of different modes of doing that. Or, but
Yeah.
a question list, or have you thought about this? And we are, I guess, with acute kidney injury in terms of sharing, we are prompting with some questions that we're building into our Epic system here for Connect Care. So stay tuned how they work. And they were created by patients with lived experience, say, that have had an acute kidney injury and acute care visits. So
That's awesome.